Thank you very much, Rox. And it is really a very exciting moment after 2 years of not being able to hug anyone. Particularly for me, it was very difficult not to hug anyone. So 1.5 days in New York City, I hugged many people, and I hope I didn't catch the bad one. So Rox, thank you very much for having me over again. It's wonderful to be here. And I have to say, even though it was a little more than 15 minutes, Alain, it was fantastic to listen to the history of TAVR from its very beginning. And I must say that many thoughts came back to me because at that time, we didn't communicate much, but we were a little bit on a different road. And I have to say, I'm very proud that maybe today, I'm giving you a little bit of a flair of what the excitement at that time was. Different. He was in France, US. We were more in France and Germany. And I have to say, listening to Alain here is not, even though you passed some very difficult times in the past, as you told me yesterday, you have not lost anything, and you haven't lost your energy, your passion, and even during your talk, we all smiled and we were very, very inspired by you. Personally, I would like to add one more thing. I don't think I would have been here without somebody that's sitting here with a white coat. He's running from one hospital to the other one. Marty, thank you very much for your support in the past, particularly as we talk about the history and talk about where we are now. Without you, without your inspiration and support, even at the very beginning, we had some different views on things, but our friendship always reigned supreme, if I may say, and thank you for your support. Some of the slides you will recognize, I'm still using Global Perspective, Financial Disclosure. It's still a little bit different from Alain. You can tell, he's a consultant. I have a little bit more still going here. Structural Hub, the beginning, and allow me just a few words about the past, even though my topic is where are we now. And this is a slide that I was very, very inspired, and this is Marty's slide. At that time, we had to overcome a lot of prejudice, and that's why he stated at that time, in order TAVR to be really a technology that would be applicable to aortic stenosis patients independent of risk and age, required a suspension of belief in reasonable body of evidence. Whatever that means, you know what it means. And the journey, I don't think, particularly in view of mitral, it wasn't that bumpy. It was pretty straightforward with TAVR devices that were different. And this is a slide I always show because it really shows you, and I tell you the point that he did not show to you. But you see this team, and you can see the tension that was at that team, because nobody at that time knew whether this thing was flying around into the aorta and the ventricle. And I will never forget these eyes. But he didn't show you that one here. He was really worried too. What is going to happen the next moment? And his hands was like a priest, Lord help me here when this comes off. Our first case was in 2004, quite different, I have to say, and you can see we were smiling. That doesn't mean that our necks weren't wet, Jean-Claude and myself. 2004, at that time, it was combined disease. And even after today's standards, the results were quite surprising. Combined disease, you can see the valve was a little low, granted, but it was really a good result at that point, and we were very encouraged when where that started. So we look at it a little bit differently. The early skeptics, this crazy and senseless project will fail and represents unacceptable and unethical experiments in humans. Well, where are we today? And I think this is a very appropriate statement from somebody that you all know. It's good to be idealistic, but be prepared to be misunderstood. Anyone working on a greater vision will get called crazy, even if you end up right. Alain, chapeau. TAVR in perspective, where are we today? Well, we know where we are today, and nobody could have predicted the rapid TAVR technology evolution, TAVR procedural refinements, and simplification, the avalanche of TAVR clinical evidence, acceptance of the heart team, very important, best practice concept basically across the companies and across the proctors, and the dramatic reduction in complication, improved clinical success. Early success was driven by several factors, most importantly, and if you look at this in view of the mitral, just inhale what we've done then, and we've done so appropriately right, and look at what we are with the mitral, but we come to that later. Standardized and consistent patient selection, the procedural best practice developed and used globally, and then, of course, the use of CT sizing for better valve selection, very important. The TAVR history, you've seen on Alain, and I don't want to repeat that, but 2002, first Edwards, 2004, first CoreValve, and then 2019, 2020, low risk and valve approval by the FDA. And this slide, can be updated, but let's not forget, we created a lot of evidence. And since 2007 in the US, more than 19,000 patients have been enrolled in FDA studies, including 16 randomized controlled trials with multiple generations of 4 different TAVR systems. And that's very important. All the TAVR systems that are there went into the same direction. We created evidence. We knew that the devices were safe, and the device success in inoperable, extreme, high risk, and intermediate risk, and obviously the low risk was to follow. And the next slide is such a beautiful slide for Marty. The importance of the low risk trial, which eventually had to come, because the most part of aortic stenosis patients fit into that category, as you can see here. That's why the results were so important. And we know the low-risk trials showed superiority/non-inferiority for TAVR compared to surgery by the numbers you can see here, both published in the New England Journal for both technologies. Eventually, that led to the approval for low-risk patients, both in the United States and in Europe. Very appropriately, the iconic person in our field in cardiology, he stated when the low-risk trial was opened, this is a historic moment, and all of us here should remember it as such. We should inhale that because it was really an important moment. So real world versus randomized controlled trials. I don't need to explain that slide in the United States. That is what's happening in Germany, the real world. And then updated meta-analysis, more than 8,000 patients. TAVR has a mortality advantage over surgery in all risk groups. TAVR has a stroke advantage over surgery, as you can see here. And then also periprocedural events also were superior in TAVR as compared to surgery, very impressively shown. However, the PVL story is still not quite over yet. In the low-risk trials, we have to say that in TAVR, so we still have more PVLs than in surgery. Which therapy do you think is better if we compare surgery and TAVR? This is also a slide inspired by Marty. But we have to see, are we ready for prime time? Well, let's talk a little bit about the low-risk trials. Particularly, this is an important one because it's being confused a lot. People talk about low risk, meaning young age, and that has nothing to do with each other. Low risk can be, and remember the trial, low-risk trial, the average age was still higher up than young age. And then not all low-risk patients are created equal. As you can see here, low-risk group, they have completely different perspective of life. So low risk is really not the answer to everything. And also, who's in and who was out. Was this a little bit cherry picking in favor of TAVR? Let us not speculate about that, but not all of it had been included. So obviously, with these great results of the low-risk trial, the guidelines followed. And you know what the guidelines are. And particularly when you see them between Europe and the United States, the difference. Basically, the gatekeeper for TAVR has changed. Now it's patient age. The procedure has to be done by transfemoral approach, and then of course the heart team is very important. And more patients older than 75 are in class 1A recommendation. US, slightly different. The age group is down to 65, and you can see here there's a difference. Remember, United States is not Europe. And when you have been sitting in the guideline committees in the United States, if you talk about California, Minneapolis, or Minnesota, and New York, they're not so much different. In Europe, if you talk about Germany, France, Belgium, Holland, Italy, Spain, they all have their different opinions apart from surgeons and intervention cardiologists. So guidelines are always a compromise. And you can always criticize and argue, but the bottom line is, it is what it is. But guidelines are guidelines. It's just a recommendation. And that's where we should think about what these guidelines exactly mean. So after a decade of rigorous clinical trials, we no longer rely on surgical risk stratification to determine TAVR versus SAVR. Instead, a shared decision should be made by the heart team. The heart team plays a central role. And the heart team, on the other hand, and a few moments on the heart team, should not be used as a regulatory tick box, but a true forum for mutual respect, trust, teamwork, and collegiality in order to bring the patients into the right track with surgery. As I see it, I can shorten that, but I think this is basically something that is quite natural if you work with your surgical colleagues in order to bring TAVR into its successful road. I think we can summarize it here. Very important, all beliefs and ideologies that is not fact or evidence-based must change and adapt with time, or it stands the risk of being ignored. And that is also true for guidelines, by the way. So heart team decisions for aortic valve replacement in low risk and younger patients are based on different long-term priorities. In the beginning, you can see on the left side, it was more procedure related. On the right side, now it's more lifetime metrics, very important. We have a great number of devices that we can choose from. Here you can see the current leaders, the ones with increasing use and the one with increasing momentum, and then some already have left the stage. Also, the differences between self-expansion, balloon expandable, and supra versus intra-annular, something that all has advantages and disadvantages, but we have a choice, and we will see that we do individualize the use of those devices in an individual patients. The current status, the challenges and opportunity are summarized here. The expanding indications today, we are expanding the remaining challenges, and then up next, we can see here, if we expand, what have we learned? And Raj Makar sitting here, he has driven this field forward on bicuspid disease. We have learned a lot, and let's not forget, look at this man. He still looks the same today. And I have to say it was a bicuspid valve that he treated at that particular time. And it's important, we learned a lot, new classifications, but we know one thing, the more calcium you have in bicuspid and the more rough is, the higher the mortality and the worse are the outcomes. A big lesson, we have new classifications that time doesn't allow to go into, but there are still known unknowns, which are the high-risk features of bicuspid aortic stenosis that preclude TAVR, sizing methodology, which valve is optimal, and do we really need a randomized controlled trial? Aortic regurgitation, I have to say, we're still struggling with that. I remember when I was in Los Angeles doing an aortic insufficiency case together with Raj, we saw this valve moving up slowly every beat, and we quickly implanted a second one. I don't know, Raj, whether you remember, but I remember very well. We just didn't have the right valves for aortic regurgitation, and now we do. We know the challenges, and now we have the Jenner valve, which is actually approved in Europe for aortic insufficiency. I can tell you, 45 patients have been done, both with aortic regurgitation and combined aortic stenosis, aortic regurgitation, with great success. So hopefully, and I believe Jenner valve is out of the dark house, and I think it's going to be very successful. Continuing on, current status, particularly stroke, reducing conduction disturbances, preserving coronary access and durability. I think John will talk about this more. This is still a controversy, whether we should use it or not. I believe that protected TAVR will give us an answer, hopefully a positive one. Meanwhile, we can use the SEP device in selective patients, summarized here by cuspid and valve, highly calcified valve or aorta, and of course, history of stroke. Procedural advancements, just to summarize, implant depth planning, don't want to go into the detail, and of course, commissural alignment for coronary access. Very important as we move into not only low risk, but also younger age, we have to guarantee coronary access. The question of durability, we know it's multifactorial, and we know there are patient-related factors and prosthesis-related factors. The question is, future will show, but I think at this point, we don't have any bad signs that durability of those TAVR valves is any different from surgical, if not maybe better. Valve thrombosis after TAVR, important, we know, and George will talk about this further. Anticoagulation and SAPT, less is more. It's in the guidelines now. Single antiplatelet therapy is something that's being recommended. So if we take home the take-home message, low risk associated with low mortality, lower risk, better results. Change in the 2021 guidelines for TAVR versus surgery moves from surgical risk as first decision criteria to age, more than 75 in Europe, more than 65 in the United States, and further broadens the patient population for TAVR class 1 recommendation. Patient decision plays a role, 1C recommendation. This is a little bit culturally different between Europe and the United States, but in Europe, there's still a special thing between the relationship physician-patient. In the United States, it's quite a little bit different, but it's anyway, patient decision should be playing a role in the decision-making process. Surgical aortic valve replacements is still the gold standard for patients less than 75 in Europe, less than 65 in the US. Until durability data and more data are available, hopefully the first results will be coming out beginning 2025. The extent and progress of coronary heart disease must implant the access route plays a role. Transfemoral is in the guidelines. Direct aortic access, transapical, and subclavian is not in the guidelines. And there's a paradigm shift, as you can see here now, not only how durable is a prosthetic valve, but also how treatable and replaceable is a bioprosthetic valve as we move into younger age. With that, I would like to finish. Challenge, provide opportunities to improve current treatment options and expand current indications. A disease state continuum of care will emerge. With that, thank you very much for your patience and your time.